Ladies and gentlemen, welcome to the IMPRO webinar, the Opioid Epidemic and Guidelines for Safer Prescribing Practices. Your host for today, Karen Herring. You may now begin.
Hello, everyone. This is Karen Herring with IMPRO, Michigan's Quality Improvement Organization that is part of the Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. With the current state of our nation's opioid epidemic, now more than ever, there is a focus on managing both acute and chronic pain in safer, more effective ways. This webinar will discuss current best practices for safer prescribing of opioids, with an emphasis on the Centers for Disease Control and Prevention Guidelines for prescribing opioids for chronic pain. Additionally, it will offer insight on how to apply these recommendations to everyday clinical workflow and treating patients. This webinar is part 5 in the series on the opioid crisis. Today's educational session is entitled The Opioid Epidemic and Guidelines for Safer Prescribing Practices. Before I introduce our speakers, I'll mention that all lines are muted during this webinar. However, after the presentation, we'll have time for questions and answers, so please make a note of any questions that may come up as you listen, or you may use the chat feature, which is on the right side of your screen. Also, because MedStar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have no conflicts of interest. For CEs or a certificate of attendance, you must attend the entire session and complete an online evaluation. You will receive the evaluation link at the end of today's session. We encourage everyone to complete the evaluation to provide feedback on the session. Now I'd like to introduce our speakers, Dr. Sarah Stoddard, Dr. Patrick Carter, and Dr. Gwen Null. Dr. Sarah Stoddard is an assistant professor in the Department of Systems Leadership and Effectiveness Science, School of Nursing at the University of Michigan. Dr. Stoddard's career has focused on promoting the health and well-being of youth and their families living in communities characterized by substantial health and social disparities. It includes almost a decade of professional experience as a local public health nurse, focused on maternal child health, a nurse practitioner in the community and school-based clinics, and as a state adolescent health coordinator for the Minnesota Department of Health. She has a Master of Science and a PhD in nursing from the University of Minnesota with a focus on adolescent health and completed a postdoctoral fellowship at the University of Michigan. Dr. Carter is an assistant professor of emergency medicine and practicing emergency physician at the University of Michigan and the assistant director of the CDC-funded U of M Injury Center. His career is focused on the intersection between alcohol and drug use, including prescription drug use and injury. He is currently conducting a National Institute on Drug Abuse funded career development award focused on developing an intervention to decrease prescription drug use as well as associated injury risk behaviors. He also recently completed a state project to examine Michigan policies related to the opioid epidemic, including those focused on prescribing practices, opioid surveillance, prescription drug monitoring programs, and substance abuse prevention treatment. Dr. No is an assistant research professor and clinical psychologist with interdisciplinary graduate and fellowship training, and a long-time commitment to improving the outcomes of our most vulnerable populations. Dr. No has interdisciplinary training in substance use research, specifically in relation to prescription opioid abuse among adolescents and young adults. Dr. Stoddard, I will now turn it over to you.
Great, thank you so much.
You're welcome.
So I'm here today really representing the University of Michigan Injury Prevention Center, and I am the director of the Education and Training Corps. And in this role, I do some education around opioid kind of misuse and abuse. We have no conflicts of interest. And today, you can see our kind of learning objectives for today. We're going to review the epidemiology of the prescription opioid epidemic. We'll discuss the origins of the opioid epidemic, discuss the relationships between prescription opioids and heroin, provide an overview of the essential elements to address the prescription drug epidemic, discuss the role of safer opioid prescribing, review the 12 CDC guidelines for safer opioid prescribing for chronic pain, discuss safer opioid disposal practices, provide some tools and resources, and then we'll happily take kind of questions and comments at the end of our presentation. So I just want to start by, kind of giving a sense of the kind of opioid epidemic and looking at some of the epidemiology. I think we all know kind of the current crisis around opioids. It's in our media all the time, but here are some kind of actual numbers for what we know. So in 2016, 42,000 people died from an opioid overdose. That's 116 people died each day. We know that there is a cost both at the individual level, but then there is a cost to society, and including an economic cost to society. So we know that the opioid epidemic really occurred in 3 phases. So the first wave was due to an increase in prescription opioid overdose due to increased prescribing in the 1990s. The second wave was really related to an increase in heroin overdose in the early 2000s. And then our third wave really relates to the availability of synthetic opioids and overdoses related to synthetic opioids, particularly fentanyl. We also know that 80% of those who use heroin had first misused prescription drug opioids. So here you can see how Michigan kind of ranks with other states across the country. So we are currently 11th, or in 2016, we were ranked 11th in the United States for opioid-related overdose deaths. And this is a 36% increase from 2015. Sorry, if I could get my... Here is a slide that looks at the opioid overdose deaths by opioid type, and this is across time. So we can see that really, for one, Michigan really looks similar to the rest of the country. And you can see that on this graph we're looking specifically at the different types of opioids as well, including heroin, including methadone. So in Michigan, the number of fatalities resulting from opioid overdose has really increased substantially since 1999, which is at the beginning of our graph. The annual number of opioid overdoses in Michigan is now greater than either firearm deaths or motor vehicle-related crashes. And then while we know that opioid overdose deaths have been stable over the past decade, fatal opioid overdoses have been increasing, accounting for 75% of all drug overdose deaths in Michigan in 2016. Here's another kind of look at the numbers. And here we can see that how it relates to admissions. And we can see that the admissions related to kind of ED visits and both inpatient hospitalizations has increased over time. And in Michigan, the opioid-related hospitalization rate in 2014 was 229 per 100,000 residents, and this is a 21% increase from 2009. So we know that the opioid epidemic has really occurred in kind of due to multiple factors, and kind of the origin of the epidemic really relates to a number of things that have happened over time. One issue is the advent of newer drugs, newer opioid products, newer narcotics, and kind of just the availability. Another issue that kind of has contributed to it is the change in viewing pain as a fifth vital sign, and the feeling that we needed to treat pain the same we same way we look at other kind of vital signs, in that people should be comfortable and that we should be assessing pain better and treating pain better. There's issues around insurance coverage, and insurance often doesn't cover kind of alternative pain therapies the same way as it covers prescriptions and prescription narcotics. And then opioids were also a way to get people back to work. People wanted to and needed to kind of resume receiving an income and getting back to their positions of employment. And opioids was a way for people to be able to do that. So we know that more prescribing relates to more opioid deaths. The impact of increased opioid prescribing is observed, as I mentioned, from the late 90s into 2000s. There was a sharp increase in both opioid pain reliever overdose deaths and admissions to the hospitals for substance use treatment, and that really corresponds with increases in opioid prescribing. And we just wanted to touch just a little bit on the relationship between prescription opioids and the transition to heroin. So we know that non-medical use of prescription opioids is a strong risk factor for heroin use. We know that the majority of current heroin users initiated their opioid use with non-medical prescription drug or prescription opioid use. And we know that only a small number of patients who misuse opioids transition to heroin use, though. So while it is a strong risk factor for heroin use later, not all people who misuse opioids make that transition. The rise of heroin overdose deaths occurred before large-scale state interventions were instituted. So we know that some of the things we are doing, have helped, but the transition to heroin is not solely an impact of state policies or changes in prescribing practices. Transition to heroin is more likely to be a progression of an addiction disease in a subgroup of non-medical prescription opioid users. So it is a specific kind of population that really transitions into heroin use. And that transition is also likely the result of market forces, including an increased accessibility, reduced prices of heroin, and a higher purity of heroin. So I'm going to hand it over to Dr. Carter to continue our presentation.
Hello. So I'm going to take over the second part of the talk, which will be about kind of an overview of how folks are looking at addressing the opioid epidemic, as well as walking through the current CDC guidelines for chronic pain and prescribing practices. So I wanted to start by saying that this talk is focused really around prescribing practices, but really it's one component of a much larger multi-focused effort to decrease opioid addiction and opioid misuse, and that includes development of the prescription drug monitoring programs, issues around dealing with diversion, harm reduction practices such as increasing availability of naloxone and needle exchange, as well as education at the community and patient level, expanded access to treatment, and improved surveillance systems. So we'll talk about one component of this and some of the pieces of it, but it's a much larger fix to the problem that's needed, and we're talking about one component today. So the reason the opioid prescribing guidelines were developed by the CDC is as this became apparent that this was a booming national crisis, there also became this apparent need to develop clear and consistent guidelines around prescribing. And the prior national guidelines were several years old, and the previous guidelines had been developed, but they were inconsistent and they were different by state. And so the CDC really put together a set of guidelines based on the current level of evidence that was geared towards primary care providers and nurse practitioners and physician assistants who are treating adult patients for chronic pain. There's some discussion in the guidelines around acute care prescribing, and we'll touch upon that too, but in large part it's focused around addressing issues around chronic pain and chronic prescribing for chronic pain. So why did the CDC choose to focus on safer opioid prescribing among primary care providers? Well, primary care providers account for about 50% of the prescriptions for opioids that are dispensed. That's nearly 2 million adolescents and adults who were either abusing or dependent on prescription opioids. And given that this was a large component of people who were receiving opioids, the thought was to focus on this sort of big-ticket item first with guidelines for primary care providers. And we have made progress. So we'll talk a lot about ways that we can improve our prescribing practices, but there has been improvement in prescribing practices, especially recently. But even despite that improvement, when you compare the prescribing practices in 2015 to 1999, we are still prescribing more than 3 times the amount that we were prescribing at that time per person. So there's still room to continue to make improvements. So the CDC guidelines are really a set of 12 recommendations that are framed around 3 specific categories. The categories are determining when to initiate or continue opioid use in the treatment of chronic pain, if the choice is made to prescribe or to continue prescribing, what opiates to select, what dosage, what duration, when to follow up, and when to discontinue use. And then the third set of recommendations are really focused around assessing risk and addressing harms of opioid use. So we're going to start by focusing on the initial focus area, which is determining when to initiate or continue opioids for chronic pain. And the first recommendation really is around the idea that non-pharmacological therapies and non-opioid-related pharmacological therapy are preferred for the treatment of chronic pain to opioid use. And a lot of this is based on the mounting evidence from the literature that suggests that long-term opioid therapy is not been shown to be effective for treating chronic pain, and that is associated with significant serious harms. And so as that evidence mounts, the idea that using opioids as a first-line therapy for treating chronic pain has really fallen out of favor in favor of non-opioid-related pain medications as well as non-pharmacological therapies. And really, opioid therapy should be considered only if the benefits for pain and function are expected to outweigh the risk to the patient. And it's really important to consider that function, because the goal of opioid therapy shouldn't be to just decrease pain, but to get the patient back to normal functioning status. And in fact, living with some pain is acceptable as long as they're functionally able to return to something that's closer to their baseline. And they should always be used in combination with both non-pharmacological and non-opioid pharmacological therapies. And some of the ones that have been shown to be effective in the non-pharmacological bucket include exercise plus behavioral therapy, such as cognitive behavioral therapy, interdisciplinary rehabilitation, physical therapy. And then in the non-opioid pharmacological therapies that have been shown to be effective, topical medications such as lidocaine or capsaicin, non-steroidal anti-inflammatories, and then in terms of second-line agents that can be thought about, serotonin and norepinephrine and reuptake inhibitors and tricyclic antidepressants. And then considering the impact or influence of neuropathic pain and treating for that with Neurontin or pregabalin, migraine therapy with beta blockers or calcium channel blockers or triptans for acute therapy, all are considerations that should be taken into account when thinking about appropriate modalities for treatment. And then for arthritic or joint pains, considering arthrocentesis and intra-articular injections of steroids. The second 2 recommendations in this initial focus area are to establish realistic goals for patient treatment and pain before beginning opioid therapy, and also to really put a timeline on that to discuss how and when opioid therapy will be discontinued if it's not proven beneficial. And the third recommendation is to discuss the risks and benefits of opioid therapy before beginning treatment, as well as periodically during the treatment period. And so this first recommendation is really about establishing treatment goals. So before initiating opioid therapy for chronic pain, there really needs to be a discussion with the patient around determining how effectiveness will be evaluated, what the treatment goals are. Often it's helpful to do a written treatment plan where you outline the plan of course with the patient, collaboratively develop collaborative treatment goals, what the expectations are for discontinuing or tapering the dosage, including such things as failure to adhere to whatever the clinical policies are of your office or your practice. And then again, the treatment goals really need to be focused around not just pain relief, but functional status. So what are the functional outcomes that the patient's looking for if you initiate them on opioid therapy? And then to really have an exit strategy up front at the time of initiating opioid therapy if it's unsuccessful. So what's your plan for tapering and discontinuing opioids? One way to evaluate effectiveness is to think about a validated scoring system such as the PEG assessment scale. This is the one that's recommended by the CDC, which includes assessing both pain and functional improvement. And they define a clinically meaningful improvement as a 30% improvement in the scores for both pain, control, and function. And then that third recommendation is really around understanding what the risks and benefits are for the treatment. So what's the expectation in terms of benefits, in terms of short-term pain management and long-term use? What are the serious potential adverse effects, both from respiratory and development of substance use disorder standpoint, as well as what are common adverse effects that they can expect? Things such as constipation or withdrawal symptoms if you stop using. And then really a discussion around the increased risk of overdose, especially as the dosage gets higher, above 50 morphine milliequivalents per day. And then the combination of opioid therapy with other medications the patient may be on, specifically including benzodiazepines, which the combination of benzodiazepines and opioids increases the risk for overdose by 10 times. And then really a discussion with the patients around other ancillary risk factors, including things like opioids and driving, and a discussion around how to store the medication safely in the home, how to dispose of them safely, what the potential risks are to other family members, especially adolescents who may be curious about these medications and find them and take them at home, and sort of the overall clinical policies around periodically reassessing whether or not you're meeting the goals with pain management, whether this is effective, and what the potential tapering plan is with the patient. So the second focus area of the CDC's prescribing guidelines is really around if you decide to initiate therapy or continue therapy, which set of opiates do you select, what dosage, what duration, how do you follow up, and how do you discontinue that medication use? So recommendation 4 really focuses around when beginning opioid therapy, the focus should be on immediate release opioids rather than extended release opioids. And recommendation 5 is when beginning opioid treatment, similar to most other medications that we prescribe as physicians or healthcare providers, to start with the lowest effective dose and to increase slowly and reassess the efficacy of the drug. So the recommendation around immediate release versus extended release opioid therapy really comes from a set of articles where it was shown that the risk of overdose is higher in patients who initiate therapy with long-acting opioids as compared to those who began with immediate release, especially during those first 2 weeks. And there's no evidence that using the extended release or long-acting versions is safer or more effective for the treatment of chronic pain. So the current recommendations and guidelines are focused around extended release or long-acting opioids should really be reserved for patients with severe continuous pain who are opioid tolerant when alternate treatment options haven't been shown to be effective. One caveat here is around the use of methadone, which should be avoided as a first-line choice in any opioid therapy initiation because of the high risk of overdose in methadone patients. And it should be noted that the risk of overdose increases with the higher dosing. This is clearly, when you get to dosages above 50 morphine milliequivalents per day, you double the risk of overdose. And as you get higher, above 90 to 100 morphine milliequivalents a day, your risk of overdose increases substantially again. And so really the 50 morphine milliequivalents per day and 100 milligrams of morphine equivalents per day cutoffs have really become a focus of when you should reconsider sort of the course that you're on with the patient and whether there are alternative modalities that can be used. And so the rule of thumb, similar to, like I said, all other medications that we use, is to start with the lowest dose necessary and go slow in increasing the dose. So begin with lower doses, titrate slowly, use caution when combining with other drugs, especially in elderly patients or patients who may have liver or renal failure. Assess for potential drug interactions. When the dosage begins to exceed 50 milliequivalents of morphine per day, that's a time to reassess the patient's pain, their function, the treatment strategies, think about other potential modalities for treatment if they haven't been tried already, and then considering at that point to think about naloxone prescribing, co-prescribing because of the higher risk of overdose potential. And then as you get above 90 morphine milligrams per day, really at that point, alternate pain therapy should be considered, tapering should be considered, and a consultation with a pain specialist is probably in order at that point. And in patients who come to you already on a high dosage, really that's the time to reevaluate their current pain management plan and to think about their overdose risk and to consider tapering or consultation with a pain specialist to think about alternate therapies. The next set of recommendations, recommendation 6 is really around acute pain treatment with opioids. And so it's really the only one of the guidelines that focuses around acute pain management rather than chronic pain management. And we'll talk a little bit about the guideline that 3 to 5 days of a prescription are probably sufficient and more than 7 days will rarely be needed. And then recommendation 7 is that if you initiate somebody on longer-term opioid therapy, really you should evaluate both the benefits of the harms with patients within 1 to 4 weeks of starting the therapy and continue to reevaluate that every 3 months or more frequently as needed. So there's 2 retrospective studies that were done that found in patients that received an opioid prescription for acute pain treatment, there was a greater risk of long-term use of the opioids when they exceeded the 7-day mark, which is really where that first recommendation comes from around merely prescribing opioids for longer than the 7 days. And this goes back to sort of these acute care recommendations where short-acting opiates should really not be used for more than 3 to 5 days and rarely is more than 7 days needed. The provider should avoid prescribing opioids just in case the patient needs it, and really they should reevaluate the patient with a severe pain that's not improving after that 3 to 5 day period and adjust their plan at that point in time. There's also some general sort of recommendations around not replacing lost or stolen prescriptions, not prescribing extended release or long-acting opioids, to consider even in patients getting acute pain management, if they're already on opioids or opioid therapy and you're increasing their opioid therapy because of acute pain, to consider whether or not you're exceeding that 15 morphine milliequivalents per day threshold and considering co-prescribing with naloxone, and utilization of the PDMP in accordance with the new Michigan laws around checking the PDMP for prescriptions that are more than 3 days in duration. The Licensing and Regulatory Administration for the state of Michigan has actually developed, in consultation with a number of groups that do research in this area, some specific specialty-specific acute care prescribing guidelines. There's a step for emergency departments, dentistry, and surgical prescribing. And these really build off of kind of the general set of recommendations I just gave. They've recently been approved, and I believe they've been given out as handouts that you can look at. And so there are a set of recommendations that providers can look at and use as they consider their prescribing practices. I did want to mention some work that's being done here at the University of Michigan by a group of researchers called the M-Open Group. They do a lot of work around post-surgical prescribing recommendations, and they have done a deep dive into the data that comes from some of the Michigan Surgical Quality Collaborative and looked at the amount of opioid therapy that patients typically use after routine surgical procedures and have come up with recommendations for opioid-naive patients who are receiving surgery on actually how many pills are needed post-intervention, post-surgery. And the recommendations meet or exceed the self-reported use of more than 75% of the patients. So they really are a nice set of recommendations around how many pills should be prescribed after different types of surgical procedures. And if you go to their website, the Michigan Open Group, you can download these recommendations and use them now guide therapy after surgical intervention. recommendations talked about follow-up after initiating opioid therapy, and there's really no good evidence regarding the effectiveness of frequent monitoring intervals. The current guidelines are around that we know that 3 months of therapy increases the risk for the development of an opioid use disorder, and that the risk for overdose is highest within the first 2 weeks of therapy, and that patients that don't receive significant pain relief at 1 month are unlikely to experience greater relief at 6 months of therapy. So the recommendation from the CDC is that reevaluating the patient within 1 to 4 weeks of starting long-term therapy or of changing the dosage is probably a reasonable guideline, and that reevaluating after that every 3 months as the patient is continuing on chronic opioid treatment is probably reasonable. And at each follow-up time point, the discussion with the patient is really focused around whether the opioids are continuing to meet the treatment goals that were set forward at the beginning of initiating the opioid therapy, and whether the benefits continue to outweigh the risks, and whether or not the patient has experienced any common or serious adverse events, and whether or not that's the time to think about whether the opioid dosage can be reduced or discontinued or at least tapered. So this brings us to tapering. So the CDC's recommendations around tapering really take 2 questions into account: when to taper and then how to taper. So the question around when to taper is really focused around when you see no sustained clinically meaningful improvement in either the patient's pain or function, when your opioid dosages begin to exceed those recommended marker that we know increases risk for overdose of 50 morphine milliequivalents per day without evidence of clinical benefit, or when the patient's already on benzodiazepines and we know that that combined risk increases the risk for overdose of about 10 times when they have concurrent use of benzodiazepines that can't be tapered, and when patients request of their own accord to reduce or discontinue their opioid therapy, or if they begin to experience any of more serious adverse events or overdose events. Those are really times to think about tapering. And there's no real good high-quality evidence that compares different tapering protocols. In general, the guidelines recommend reducing the dosage by anywhere between 10 and 50% of the original dosage on a weekly basis. 10% is a reasonable place to start, and if the patient's making good progress, you can taper faster than that. If they're beginning to experience significant withdrawal symptoms, you can consider tapering more slowly or considering co-prescribing clonidine for the withdrawal symptoms. Opioids can be stopped when the patient is down to taking less than 1 a day. More rapid tapering may be indicated for patients who have more adverse events, such as overdose. And really, it's a time not just to taper, but also to think about how to optimize pain management with non-opioid-related pharmacological and non-pharmacological methods, and to provide the additional psychosocial support that the patient will need as they begin to withdraw, especially if they're on higher doses of opioid therapy and have been on high doses for a long period of time. And so patients who you suspect have a substance use disorder or significant dependence on the drug, it's an appropriate time to think about referral to treatment services. The last set of guidelines are really focused around assessing the risk and addressing the harms of opioid use. So recommendation 8, before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk factors for opioid-related harm. And so this comes from the evidence of literature around overdose education and naloxone distribution. So patients who are at potential risk for overdose and harm should be considered for co-prescribing naloxone therapy. These are patients who have prior overdose, who have a history of substance abuse, patients who are on higher doses of opioids, who are taking an opioid or being prescribed an opioid pain medication and are also receiving methadone or buprenorphine, who have evidence of obstructive sleep apnea or poorly controlled respiratory disease, underlying renal dysfunction or hepatic illness, patients who are concurrently taking alcohol or benzodiazepines because of the increased risk of overdose, and then really some special populations such as the elderly, where falls or complications of opioid therapy may be more prominent, and then pregnant patients. Patients who are resuming their opioid use after a period of abstinence or have recently been incarcerated and had a history of opioid abuse and are just released, that's another high population for potential overdose risk. And then patients who are in more remote or rural locations who may have delayed access to EMS services if they overdose, that's the time to consider co-prescribing with naloxone therapy. There's an abundance of literature at this point that demonstrates both the feasibility of using naloxone distribution as a prevention tool, increasing the knowledge and skills of patients. There's a significant amount of literature that shows there's no increase in drug use when patients receive naloxone therapy. There is, however, an increase in drug treatment, that this is a cost-effective prevention intervention, and that there can be an overall reduction in overdose deaths within communities. It's often helpful to prescribe, and I would say best practice when prescribing naloxone to also provide a fair amount of education. There are a number of different formulations out there, including auto-injectors, intranasal, and then the standard, more traditional intramuscular variety. I think the intranasal is gaining the most popularity at this point due to the cost and ease of distribution. And there are a number of kits that can be prescribed that provide both the education piece and the training that's needed for the provider or the bystander, and provide the medication itself. Recommendations 9 and 10 of the CDC guidelines are around reviewing the patient's history of controlled substance use through the PDMP, the Prescription Drug Monitoring Program in Michigan. That's called the Michigan Automated Prescribing System. And also when prescribing opiates for chronic pain, to consider using urine drug testing before starting opioid therapy, and periodically during treatment to assess for non-prescribed medications or illicit drug use. So for those who don't know, I'm sure most of the providers on the phone probably are aware that the Prescription Drug Monitoring Program is an electronic system that digitally stores, monitors, and analyzes substance use dispensing data. 49 states have implemented the PDMP. It collects information both at the patient and prescriber level, and then any information on Schedule 2 through Schedule 4 drugs. The PDMP can be accessed by prescribers, it can be accessed by pharmacies, law enforcement, and state medical boards. It's used primarily as a surveillance and evaluation tool, and to identify outlier prescribers and especially outlier patients who may be doctor shopping. The PDMP has mixed evidence for effectiveness in terms of overall reductions in overdose. However, it has been shown to reduce opioid prescribing in several states, and some increases in treatment admissions in some states. But the findings have been somewhat mixed by state and substance type overall. Lots of PDMPs provide provide evidence at different levels. In essence, what you're looking for when you examine the PDMP system is whether or not the patient's dosage of current opioid therapy is starting to exceed what we would consider to be a high dosage, that 50 morphine milliequivalents per day or more. Looking for whether or not the patient is receiving opioid therapy from multiple providers, and looking for whether or not they're being co-prescribed to other Schedule 2 through 4 medications that may relate to drug interactions or increase their risk for adverse events such as overdose. Michigan has the Michigan Automated Prescription System, which is its form of the PDMP. It was initially rolled out in 2003, and they've just rolled out in 2017 a much more advanced and upgraded platform and system, and it's being started to be integrated into some electronic health records, and there's some clinical decision support with the NARC score, although that score has not been validated to date. It is a somewhat useful tool to help identify those patients who might be at increased risk from their current opioid use. And I did want to just touch upon the recently passed Public Act 248 and 249 that says that all licensed prescribers in Michigan must be registered with MAPS before prescribing or dispensing controlled substances, and that they should query MAPS if they're planning to write for prescriptions for more than a 3-day supply for a patient. The final two recommendations, 11 and 12. 11 is really around that increased risk of co-prescribing when you're prescribing an opioid and a benzodiazepine, and to consider possible non-pharmacological and opioid-related pharmacological therapies. And then recommendation 12 is around the availability of medication-assisted therapy with buprenorphine or methadone treatment. So medication-assisted therapy is a comprehensive method of addressing opioid use disorders by combining medications, behavioral counseling therapy, and case management services. Both methadone and buprenorphine are approved by the FDA for the treatment of opioid use disorders, and injectable extended-release naloxone has been approved to prevent relapse after detoxification. This schematic didn't come through totally here, but I think the first box is methadone, the second box is buprenorphine, and the last box is naltrexone. They each have benefits and risks to their use and different levels of prescribing practices, and buprenorphine requires office-based prescribing with a DEA waiver or license for patients, and the naloxone is effective for treating both alcohol and opioid use disorders, but requires the patient to be opioid-free for 5 to 7 days before initiation. So I'll let folks look at those in general. There's some differences between them. But I did want to mention that overall medication-assisted therapy has a significant benefit, both at improving treatment program retention, reducing opioid use and misuse, reducing overall criminal activity, reducing the risk of overdose and opioid-related overdose deaths, reducing the risk of infections that may come with IV drug use, such as HIV, Hep B, and Hep C, and increasing rates of employment and overall social functioning. I did want to briefly mention, although it's not one of the recommendations, that another area to counsel patients is around what to do when they're done with their opioids and how to counsel patients to dispose of them. And the safest method is to get a small dose up front, but in lieu of that, you can use one of these take-back programs that are available at pharmacies or through law enforcement agencies, or special take-back programs that are held in the state. And here's a schematic for Michigan. You can go on the Michigan Open website and find a local take-back program that's available within your community, and pass that information out to the patients in your practices so that they know where to go to get rid of opioids that they don't use. If there is no availability for a take-back program in the community, then there's some simple instructions that you can give patients to dispose of these medications in their trash. They should mix the medications with a substance such as dirt or kitty litter or coffee grounds, put it in a sealed container, and throw it out, and then they can throw out the medication bottle separately. And then I will turn this over now to Dr. No to talk about the last segment of this talk, which is around having the conversations with patients around opioid therapy and some of the challenges that
Good afternoon, and thank you for joining us. So I just want to take a few minutes to prod some thoughts on having difficult conversations with patients. Here on this slide, we actually have an exercise that we often do with groups in person. But I would encourage you to take a few minutes right now and to just think about a situation where you may have had a conversation that you dreaded to have with a patient about the treatment of chronic pain, or where you had a conversation and you weren't quite sure whether how you handled it was the thing you should have done, or whether if you're looking back now and wondering if you would have handled the situation similarly, or if you would have done something different. Oftentimes, hindsight is 20/20, but in thinking about chronic pain patients, there are often times that these patients can be really challenging to deal with.
there seems to be a cycle that sometimes happens where chronic pain patients may feel like their care providers don't believe them or other people in their lives don't believe them. And so when they experience their chronic pain, this can get very frustrating for them. And whether or not they're receiving that sort of treatment from you, you're sort of at the receiving end of this when they come into your office. And so it can create this cycle where they are frustrated and angry because nobody believes them, and they come in and talk to you and sort of take things out on you, which makes it a difficult situation for you. Because we're all human, and there are days when providers also have rough days or tough days, and so when you're confronted with this, it can be very difficult for you. And so one thing that I would encourage, and I know that this often comes up with all sorts of training, but is to really take care of yourself beforehand if you are dealing with chronic pain patients, because it can be a very challenging situation to deal with. So really thinking about taking that deep breath before you walk into that office, or you could even do some very mindful walking or moving from one office to another office, and just taking that moment if you know that you're going to have a difficult conversation to really prepare yourself and to calm yourself as best you can before you walk in there. So some important things to convey to patients is really that you are listening, you hear them, and that you believe them. As I mentioned before, many chronic pain patients feel like nobody believes them. Oftentimes they're characterized as perpetual complainers, and not only are their care providers sort of at their wit's end, but so are the people in their lives. And so they really are feeling like nobody believes them and nobody hears them. So it's really important to convey that you really are listening to them, and that you also care and that you want to help. Now, this can be a challenge given the limited amount of time you may have during your appointments to meet with chronic pain patients. But this will make your life much easier, and it will really increase the likelihood of cooperation from the patient as well, if they really feel like the decisions that you're making are based on your wanting the best for them. And as care providers, I think we sort of assume that a patient would know this, but it's not always clear to them. And so making very explicit and clear to them that you care about what's happening to them and that you really are wanting to help them. The other thing that I think is important to bring up is that when you're recommending non-pharmaceutical treatments, that you really make it clear that this is not because you aren't believing them or because you think they're crazy or this is all part of some mental illness that they're experiencing. Really talking to them about the role of the brain in the experience of pain, and that by recommending other approaches that are non-pharmaceutical, that you're really helping to address this pain from multiple ways and multiple lenses and positions. And talking to them about the fact that pain plays an important role in telling us that there's something wrong with their body. So that is a signal to them that there's something that's not working there, but that and that they may not necessarily lead to a pain-free life, but that they can return to functioning. And as Dr. Carter mentioned earlier, that the emphasis really is on increasing their functioning and helping them to find ways to make their pain tolerable. I know that Dr. Carter also mentioned pain specialists before. There are also some other alternative treatments that can be very effective depending on the patient and what he or she may be open to. So mindfulness-based stress reduction, I know mindfulness is very hot in the media right now. Everyone's talking mindfulness, and I often get a lot of eye rolls when I mention mindfulness. However, mindfulness-based stress reduction in particular was actually developed with chronic pain patients. So John Kabat-Zinn and his colleagues at the University of Massachusetts had this little clinic, and they were actually sent all of the patients that other areas were struggling with, that they were chronic pain patients that who were non-responsive to other treatments. And so this specific treatment was developed for chronic pain patients. And it isn't that it cured the pain or made everything 100% better, but it really did improve the quality of life for many of the chronic pain patients. So this is one way, one recommendation that you could have for patients who are dealing with chronic pain. Another approach could be Tai Chi, which would be great for improving balance. And it's also gentle on joints. It's not a high impact activity, and so can also help with chronic pain as well. And finally, acupuncture, which is actually one of the first lines of treatment in other countries such as Australia for chronic pain, where many chronic pain patients are treated with acupuncture first. And there are actually more and more insurances in the United States that will reimburse for treatment with acupuncture. There's evidence that Verum and sham acupuncture actually perform better than opioid treatments. And so whether or not it's true acupuncture or someone sitting there and just sticking a needle, an acupuncture needle into the patient, there actually were reported greater reductions in chronic pain than patients who were using allopathic treatments of opioid prescriptions. So these are alternatives to treatment, and also if pain specialists and the treatment from pain specialists may not be working, these are other ways that chronic pain patients can be treated that will not only potentially improve their experiences of pain, but also their overall quality of life. And so here we have tools and resources that are available to you. These are from the CDC, and so you'll have access to these slides and be able to access these additional resources as well. So at this time, we are wrapping up the didactic portion of this. And so if there are questions, Dr. Stoddard, Dr. Carter, and I are all available to answer questions.
Thank you very much, Dr. Stoddard, Dr. Carter, and Dr. No. We now have time for questions or comments from the doctors. Operator, will you please remind our participants how to get into the queue for questions or comments?
Ladies and gentlemen, if you have a question at this time, please press the #1 key on your telephone keypad. If you have a question at this time, please press the #1 key on your telephone keypad. We're waiting for callers to join the queue.
We do have one question in the chat. This comes from Connie Gibson, and she writes, I see that acupuncture is included in the alternative method for pain control. What about acupressure? The example would be SEVA, S-E-V-A.
Yes, so this is Dr. No, and acupressure is also a potential treatment for chronic pain as well. And so there are more and more alternative treatments that are being researched at NIH as well with regard to chronic pain. And so if you are interested in some of these alternative treatments, the National Institutes of Health actually have an institute that is specifically focused on complementary and alternative medicines. And so you can always go to their website and see what the latest is with regard to empirically supported complementary and alternative medicines.
Thank you. We have another question from Mark Strand, and he asks, when and how is risk of opioid misuse assessed? I don't see it being done at the primary care level.
So this is Dr. Carter. I think that's part of the purpose of the CDC guidelines is to really try and reinforce that assessing this with patients at a regular interval every 3 months is what the CDC guidelines say, or at the time of initiation of opioid therapy is really a critical component that should be done throughout the primary care setting, whether that's emergency departments or primary care providers or urgent care clinics. That it should really be we should start to introduce this in our practices if we're not doing it currently.
Thank you. I have another question. This is from Brenner Rollison. Regarding the new law for prescribing opioids in the state of Michigan, do you know if refills can be given for Schedule 2 through 5 opioids if a 7-day quantity is administered?
So I'm not a legal expert, and I don't know the laws that well, except to know that I believe before providing another prescription, you would need to assess the Michigan Automated Prescription System. I don't know if that applies specifically to refills or if you have to prescribe a new prescription. That's a question I'm not sure about.
Thank you, Dr. Carter. That is it for the chat. Are there any in the queue?
Ladies and gentlemen, if you have a question, please press the number 1 key on your telephone keypad. If you have a question, please press the number 1 key on your telephone keypad. We are waiting for callers to join the queue. There are no further questions at this time.
Thank you very much. This concludes the educational session. Thank you again, Dr. Stoddard, Carter, and Noel for speaking with us today. When you exit the webinar, you will see a pop-up screen that contains the evaluation access information. Be sure to complete the evaluation if you would like CME or CNE credit or a certificate of attendance. If you don't want a certificate, please complete the evaluation as your feedback is very important to us. Again, when you exit, please access and complete the evaluation. We love your feedback. If you have any questions about continuing education or the evaluation, please contact continuinged@medstar.com. This session was recorded and will be available on the Lake Superior Quinn website in about 2 weeks. Thank you all for participating and have a great afternoon.
Ladies and gentlemen, this concludes the call. You may disconnect at this time.